Hello, good morning, everybody. It's a great pleasure and an honor for me to be here, and I thank the scientific committee for this kind invitation. Well, my topic will be EBUS TBNA, not only mediastinum. This is my conflict of interest disclosure. Well, this is the history of bronchoscopy. A lot of steps and a lot of new technology. But if we have to look at this history, we see that there are just few steps that really changed our way to perform bronchoscopy. Of course, the introduction of flexible bronchoscopy, the introduction of a flexible TBNA that opened the door of mediastinum to the bronchoscopist, and the introduction of EBUS TBNA. These are the pioneers of EBUS TBNA, as Professor Hert already showed us, Mark Krasnik, Casimiro Yasufuku, and Felix Hert. They demonstrated that the sensitivity of EBUS TBNA for staging was greater, higher than 94%, with a very, very high specificity. And according to this data, as Professor Hert showed us, some years later, EBUS TBNA was introduced as the first step for mediastinal staging in lung cancer by the guidelines. These are guidelines from the American College of Chest Physicians, but all the guidelines introduced EBUS TBNA for the staging of mediastinum. However, with the use of the convex echobronchoscope, in the following year we realized that such instrument was useful not only for the mediastinal staging, but also for diagnosing other conditions like pulmonary lesion, like some peripheral lesion in the lower lobe, like some pleural lesions adjacent to the mediastinum. The possibility to diagnose endovascular lesion was also possible. And with the EBUS probe, with the echobronchoscope, pulmonologists learn to go through the esophagus. Esophagus is a motorway that is going through the thorax, and thanks to the echobronchoscope, pulmonologists learn to use this way. I would like to show this possibility with practical example, with practical clinical cases that is the main topic of my presentation. Start with the diagnosis of pulmonary lesion adjacent to the airways. You can see here a pulmonary lesion in close to the trachea. Well, the possibility to perform EBUS TBNA, the lesion is very well visible if you put the tip of your echobronchoscope on the lateral posterior angle of the trachea. And this is the diagnosis, was squamous cell carcinoma. Going close to the main bronchi, you can see here 1 centimeter lesion adjacent to the right main bronchus. It's very easy to visualize this lesion and to sample using EBUS TBNA, and you can have a diagnosis of adenocarcinoma. It's very easy. Going more in the periphery, this is another lesion that is close to the right main bronchus. You can see the echobronchoscopic view, the needle inside the lesion, and it was an hematoma. Here is a lesion that is close to the left main bronchus at the beginning of the left upper lobe bronchus. And you can see here the possibility to visualize the pulmonary artery that is close to the lesion, and very well the lesion that it's easy to sample using EBUS TBNA. And again, this is an adenocarcinoma. But if we move more in the periphery, you should know that it's possible to wedge the tip of your echobronchoscope in the segmental bronchi. For instance, these are two cases of lesion in the middle lobe. If it's possible to wedge your echobronchoscope in the middle lobe bronchus, and such lesion can be easily visualized, look at, and the fluoroscopic view of your echobronchoscope into the middle lobe bronchus, and the diagnosis was carcinoid in such case. And again, another lesion in the middle lobe bronchus. Insert your echobronchoscope peripherally to the middle lobe, into the middle lobe, and you can visualize the lesion also in this case. And here is the fluoroscopic view of your echobronchoscope, and the diagnosis in such case was adenocarcinoma. This is Galileo Galilei, an Italian scientist that in 1564 was born close to Florence, and it's very famous, his sentences, and yet it moves. It was referred to the heart. But yet it moves, we can also refer to the trachea. The trachea can be moved inside the mediastinum. And if you have a lesion, like in this case, that is not adjacent to the trachea, there is no problem. Bend the tip of your echobronchoscope, move the trachea toward the lesion, and put the trachea in contact with the lesion, and you can visualize the lesion, and you can get diagnosis even if there is 1 centimeter distance from the trachea to the lesion. Peripheral lesion. You can try. If you have a bronchus greater than 3-5 millimeter, you can wedge in that peripheral bronchus the tip of your echobronchoscope. And you can see here the very small peripheral lesion in the right lower lobe is 1 centimeter more or less, but there is a bronchus that is 5 millimeter very close to the lesion. If we put our echobronchoscope in this peripheral bronchus, we can visualize very well the lesion, and the diagnosis was carcinoid. Look at this nodule, 8 millimeter nodules in the right lower lobe. If a patient came to your hospital with such a lesion, what do you think? What is your approach? You can think, oh my God, I don't have combin CT, I don't have robotic bronchoscopy, or it's very difficult to perform percutaneous needle aspiration of such a small nodule. But if you look carefully to the CT scan, you will see that there is a bronchus, 5 millimeter, that is close to this small nodule. Well, if you are able to insert the echobronchoscope in such subsegmental bronchus and to wedge the tip of your echobronchoscope, you can visualize this 8 millimeter nodule, and it's possible to perform a safe sample with a high probability of diagnosis. And this case was a metastasis of urothelial cancer. So another very small nodule with a large branch of the pulmonary artery very close. So in this case, even it's difficult to hypothesize such approach using the tools that we have for peripheral lesion. You can visualize with your echobronchoscope inserted in this small bronchus that is close to the lesion. You can visualize the artery, you can visualize the nodule, and you can perform the sample in a safer way without involving the large branch of the pulmonary artery. Now we are on the left side. This is a peripheral nodule of the left lower lobe. You can see there is a very evident bronchus very close to the lesion, adjacent to the lesion. And you know that using a mini probe, radial EBUS, when you have a lesion that is not in but is adjacent to the probe, the possibility of diagnosis are lower. In such case, you can visualize such lesion and you can perform your biopsy. Another nodule of the left lower lobe, and again, the echobronchoscope wedged in the periphery of the left lower lobe, and the sample performed demonstrated that it was lung cancer, probably adenocarcinoma. Another very small nodule of the right lower lobe. Here is your echobronchoscope wedged in the periphery, the visualization of the nodule, and the diagnosis was a metastasis of melanoma in such case. And look at the number 13. There is a nodule very close to a bulla of emphysema, high risk for pneumothorax if you perform a percutaneous needle aspiration in such case, where we can insert our echobronchoscope in the periphery of the left lower lobe, and we can do diagnosis of such nodule that was lung cancer, adenocarcinoma again. Look at this. This is the first case, to my knowledge, where the echobronchoscope was inserted to this nodule that is close to the diaphragm and to pericardium. And this is the first image of pericardial sliding observed to an echobronchoscope. Sorry, this was close to the diaphragm, number 14. Number 15 is close to the pericardium. And you can see here the pericardial sliding in this moving. It was possible to sample this lesion that was a metastasis of breast cancer. And you can see the pericardium observed through the linear echobronchoscope. We collected about the first 30 patients that we did with the pulmonary peripheral nodule less than 3 centimeters. The limit of this technique is that it's not possible to sample nodule located in the upper lobes because it's difficult, it's impossible to insert in the periphery the echobronchoscope in the upper lobe. So these 30 patients had a nodule located in the lower lobes bilaterally, and it was possible to visualize with endoscopic ultrasound the nodule in 28 patients, and in this 28 patient diagnosis was obtained in 86.6% of cases, and 92% if only the 28 patients in which the lesion was visualized were considered. No adverse event with this technique. The esophagus, I mentioned it before, is a separate way through the thorax, and is a new way, thanks to the echobronchoscope, is a new way for interventional pulmonology. We can sample lymph node not adjacent to the airways, like station 8 and 9, and we can sample also paraesophageal lung lesion, paraesophageal pleural lesion, liver metastasis, and left adrenal gland metastasis. You can see here a pulmonary lesion that is very close to the esophagus, and we can visualize very easy this lesion inserting our echobronchoscope into the esophagus and make a sample. Here is another lesion. Also, the esophagus can be moved into the mediastinum by bending our echobronchoscope and bringing the esophagus in contact with the lesion, even if there are 1 or 2 centimeters of distance from the lesion and the esophagus. And this is a large mass of the left upper lobe that can be easily visualized through the esophagus. This is a pleural involvement, and you can see through the esophagus how this pleural mass was well visualized. And look at this lesion that is adjacent to the vertebral bone and to the spine, and is PET positive in a patient that already underwent a surgery, upper lobe lobectomy for adenocarcinoma. It's difficult to sample in other way, but there is the esophagus that is close to this lesion, and you can see here the sampling and the visualization and the sampling using endobronchial ultrasound, transesophageal ultrasound bronchoscopy and fine needle aspiration. Unfortunately, it was a recurrence and localization of adenocarcinoma. This was a mesothelioma, a mass, pleural mass, intensively PET positive, and you can see here the needle inserted through the esophagus, the visualization of the pleural mass and the sample to diagnose a mesothelioma in this case. It's possible, of course, to sample left adrenal gland metastasis. This is the normal appearance, like a bird, of a left adrenal gland, and this is a metastasis, left adrenal gland metastasis, diagnosed using ultrasound transesophageal approach. Well, the possibility also to diagnose vascular lesion. There are several papers that demonstrate that it's possible to make a differential diagnosis between pulmonary embolism and pulmonary artery tumors like sarcoma. You can see here how we can visualize a pulmonary embolism using our EBUS TBNA, and the possibility to have a neoplastic embolus close to the tumor, like in this case, this is neoplastic embolism that was close to a pulmonary mass, very well visualized using our echobronchoscope. Well, someone can ask, but it's possible to have also a molecular evaluation of the samples that we have for such pulmonary lesion. There are a lot of papers that demonstrate the value of EBUS TBNA in the molecular characterization of pulmonary tumor. The most important step is the correct management of the sampling. We routinely used both smeared cytology and core biopsy cell block for histological evaluation. And through a single pass of EBUS TBNA, you can see here how many tissue, how many core you can obtain. This is a single pass, and the amount of tissue is much more than one single forceps biopsy that you can obtain. So, in conclusion, EBUS TBNA changed our diagnostic approach to pulmonary tumor and to pulmonary lesion, greatly increasing the sampling possibility of bronchoscopy. Of course, EBUS TBNA is a very important means for lung cancer staging and for diagnosis of hilar mediastinal lymphadenopathies, but it is also an invaluable instrument for diagnosis of several pathological conditions involving other structure close to the airway and to the esophagus. Most important thing is the correct management of samples that is always necessary to optimize our results. Thank you very much for your attention, and this is the hospital in Milan where now I have the luck and the honor to work. Thank you very much.